Thanks for having me on.
Thank you for joining us. And it took us a minute. We got the technical problems all worked out before you came, so we're ready to go.
Sounds good. Sounds good.
uh, so thank you for coming back. For those of you who weren't at last year's meeting, this is Dr. Narang, and she addressed us last year about Ozempic and all of these new medications that people are taking for weight loss. And we want to get an update and talk about what's happening
Yeah.
last time we met, and then talk about how they work for heart patients and what heart patients need to know. Uh,
Yeah, I am wanting to just pull up the email you sent me with all those questions.
I was looking for that too, actually. So
Yeah, let me let
let's
me
find
find
that.
that. Oh, here we are. I found it. Okay, here we are. And then obviously if there's any other questions that come up, feel free. I'm just going to kind of keep this sort of open-ended and I don't have any formal slides or anything.
No, that's
Um and so just to kind of recap, so I guess, last year when we spoke, and there might be different folks on this today, but just to sort of review, what we're talking about. So, we are of course like talking about cardiac disease and its connection to obesity. But one thing I want to touch on is Ozempic and Wegovy, um, they are both semaglutide, but Ozempic is only approved for patients with diabetes, and um, Wegovy is only approved for patients with obesity. And for our Medicare population, it's particularly approved for patients who have obesity with a history of heart attack, stroke, or a blood clot or something like peripheral arterial disease. So, because people often confuse, oh, like, I want Ozempic and that sort of thing. So if you don't have diabetes, you're not going to be approved to take Ozempic. Um, the other major medication that is out there that works kind of like Ozempic and Wegovy is tirzepatide. And so that's Mounjaro for diabetes, and Zepbound for weight management. Now, Mounjaro, again, if you don't have diabetes, you cannot be approved for Mounjaro. But if you do have diabetes, Medicare has successfully been approving Mounjaro for patients with diabetes. It still depends, on your policy and all of that to figure out what copay and those sorts of things are going to be. However, I actually just spoke to those people today that Mounjaro has improved approval rates for patients with diabetes. Um, Zepbound has not been approved yet in the Medicare population, but it's definitely going in that direction. So again, Zepbound is approved for medical weight management, and it just got an FDA approval for patients who have sleep apnea and a history of obesity. We've also now seen studies in improvement in heart failure. And so there is definitely a lot of relevance, especially in our group here tonight, where we do see very significant improvements in heart disease. With either of these medications, either with tirzepatide, again, which is Zepbound, or semaglutide, which is Wegovy. Um, so just to also go over this, so when we say approved for medication, the insurance companies go via body mass index, your BMI. So by guidelines, a BMI of 27 or above with a weight related comorbidity, which means something like sleep apnea, heart disease, diabetes, high blood pressure, cholesterol, even osteoarthritis like joint disease, you could be eligible for a weight management medication, or above a BMI of 30 without any other concomitant disease. So, um, the only thing though is Medicare again is highly restrictive currently. Now, the biggest limitation because of, from this is because these medications are so expensive. And so, out of pocket, it can be over 500 or $600 a month for these medications if insurance doesn't cover. So, it is kind of prohibitive from a cost standpoint. However, again, in this group that has a history of potential heart conditions, Wegovy certainly already is approved by Medicare and private insurances. Also, if you don't have Medicare, and I have a feeling there is going to be approval for Zepbound, hopefully soon, especially for that population that has sleep apnea, because private insurances are already starting to cover it, as of literally the last week or two. So hopefully that's a positive thing, in terms of coverage for folks. So we have seen actually only good things recently as we have more and more research on these medications. Now, we even now have a head-to-head trial between Zepbound and Wegovy. And in terms of weight loss, Zepbound has a few more percentage points of weight loss, up to about 18 to 19% excess body weight loss, whereas Wegovy has about a 15% excess body weight loss. However, by and large, these two medications are the only medications we've really ever had to really combat weight management safely long term, which is really exciting. In terms of side effects, again, there's so much stuff out in social media and a lot of misinformation, and I feel like I spend most of my days trying to correct the misinformation. But the biggest side effects that we experience are GI related, so potentially nausea, indigestion. Some people might have, vomiting, constipation, diarrhea, just so all kind of stomach related things. However, when we look at the trials, about 96% of patients can actually tolerate either of these medications. And so that's actually very, very different than a lot of the stuff that we hear, someone's friend or family member, whatever, or on social media or the news or something like that, because a lot of it is sensationalized. And so if you go and check like a Google something or other forum, you know that the people who are sort of out there complaining are the ones who are probably experiencing the side effects, but the people who are doing well aren't really on, social media forums posting about this stuff. They're living their lives. And so it's really, really important to kind of follow the data, follow the evidence, and understand why you might be a good candidate for it, or why you might not be a good candidate for it. Patients who might not be great candidates for it are people who might have like ongoing GI disease, like let's say you have really bad reflux disease, or you have a history of inflammatory bowel disease like Crohn's or ulcerative colitis or something like that. If you have a history of pancreatitis, you might not be a good candidate for it. So certainly some people might not be great candidates for it, but by and large, most people are good candidates for it, especially if you meet the criteria in terms of, weight, and especially, in this population, a heart history. And so, the way that we help patients tolerate it better is that we start at the lowest dose and we go up very, very slowly. So insurances tend to have a different opinion than me about this, but I like to go up as slow as possible. So, if you're doing well on the lower dose, I feel no need to keep going up just for the sake of going up. I like to, maximize benefit on the lowest dose and then go up very slowly as needed. Unfortunately, insurances sort of force patients to go up every month. And so I try to kind of slow that process down as much as possible because there's no guideline or necessity to just go up every month for the sake of going up. And so, in my opinion, I think, the lower dose, the better. So if you're actively losing weight on a lower dose, there's no point of going up. But that's my opinion. Unfortunately, insurance doesn't agree with me on that.
Doctor,
And so
where's the weight threshold? I mean, how overweight do you need to be before?
yeah, so recall that I said 27 or above, a BMI of 27 or above with a weight-related comorbidity, or above 30 without another weight-related comorbidity. And so for the Wegovy guidelines, you have to have that BMI threshold in addition to a history of a heart event like a prior heart attack or placement of a stent, a history of peripheral arterial disease, or a history of a stroke. And so those are the three different criteria that currently Medicare is covering for patients who might be eligible for Wegovy.
Someone needs to know their BMI. They can't just say, well, I'm 10% overweight or I'm 20% overweight.
Yeah, I mean, insurance is going to want that information anyway. And so whenever you do go to the doctor, that's information that when we check your vitals, for example, that your height and weight is something that we check.
Yeah. And I think there are apps that will tell you your BMI too.
Oh, sure. Yeah. So as long as you know your weight and height, you can easily get a BMI calculator online. Yep.
And talking, you touched on insurance. What are the differences between Medicare, how it deals with it? Because I thought Medicare wouldn't cover weight loss medications.
The only one that it covers is Wegovy, and that's for our patients who've had a history of heart disease.
Any type of heart disease, or are there specific?
Again, past heart attack, peripheral arterial disease, or a history of a stroke. Those are the only conditions. So right now, we don't have approval for Wegovy in our Medicare population if you have a history, for example, of CHF, like congestive heart failure. We don't have approval yet. We are hoping to, have that potentially for Zepbound and Wegovy. I just don't know when that's going to happen. All our research points to benefits in patients with congestive heart failure as well.
What about atrial fibrillation?
Yeah, there's significant benefit of weight loss in patients with atrial fibrillation as well. So if the patient has a history of being overweight,
Uh-huh.
and a history of AFib, certainly weight loss has been beneficial. However, insurance has not proved that yet.
Got
So
it.
again, future state, I really, really do hope that that does get approved, but right now we don't have approval.
Okay.
And sorry to interrupt. Some private insurances, so let's say you are not a patient with Medicare, some private insurances still have approval for weight management, whether or not you have a history of heart disease. So if you have private insurance, and you have this heart condition, you may be very well eligible for Wegovy, with whether you have Blue Cross or something like that. And so, it's always, always, always beneficial to have a good understanding of, what is your insurance coverage, even going, before going in to see the doctor. It
And
makes
does
it
that
makes our
depend on,
lives a little bit easier. Huh?
I'm sorry, does that depend on which plan D you have? Because at one point, my Medicare did pay for Ozempic and then it stopped paying. So I still have the
Yeah.
same plan, but when I looked up on the plan, it doesn't mention Wegovy, but now Medicare covers it. I wonder if that's going to be new for this year.
Yeah, so again, it totally depends on your policy, but again, Ozempic is only for patients who have a
Yeah.
diagnosis of diabetes. So your Medicare mostly does cover Ozempic, but only if you have diabetes. So if you do have diabetes, it would, it's like obvious to just do, it's all the same, right? With it's semaglutide, whatever. It's just marketed differently. And so if a patient, for example, comes to see me and they have diabetes and a history of heart disease, well, you bet I'm going to go for the Ozempic because I know it's going to be covered, even though it's the exact same medication. So a lot of this is just games we have to play, with insurance, unfortunately, but that's kind of how we get around it to make sure that our patients are getting the treatment that they deserve.
So a heart patient with diabetes should just go for Ozempic.
Go
Yeah,
for Ozempic, or you could go for Mounjaro as well.
right. I do not have diabetes, but for some reason it did pay for it for the first year, but I do have stents. And then it stopped
Yeah.
paying.
So
So
here's
now
the
I'm gonna
thing.
have to look at
In the last
Wegovy.
year or two, the insurance companies have really wisened up to this because we were sort of putting in Ozempic for everyone, before Wegovy really came out, and insurances didn't really say much about it. But because the demand went so, through the roof in the last couple years, this is why insurances have really cut back on coverage for all of this because everybody wants it, right? It's like
Mhm.
liquid gold these days. And so, we were able to kind of treat patients quietly for years before it sort of became mainstream media.
You got caught by the publicity. Huh?
I know. No, too many people found out about what we were doing.
What about one of the questions I sent you was about Zepbound. Is that a different type of drug? Can you explain where that fits?
Yeah, so the difference between Wegovy and Zepbound is that Wegovy is a GLP-1 agonist. Zepbound is GIP and GLP. So it's just another hormone peptide that they've added to the GLP-1 agonist, but by doing that, it's a bit more powerful, from a weight reduction standpoint, but also a blood sugar reducer standpoint. for patients. And so the other thing I've noticed is actually that the GI side effects tend to be a little bit less on the Zepbound than they do the Wegovy. And this might be more anecdotal, but I've also been doing this for years. So, but patients do tend to feel a little bit better on the Zepbound or Mounjaro versus the Ozempic versus or Wegovy. But it's like slightly more powerful.
They're all injectables, right? Is that correct?
They're all injectables, so they're one-time use injectables. So you take one shot, throw it away, and the next week you get another one. They're very, very easy to use. You don't have to see or handle the needle. You just press a little button. It gives you the shot. You shouldn't even really feel it, and then you toss it and you get a new one out the next week.
Is there any prospect of that changing where you can just take a pill?
Well, so Zepbound does have vials available, but only at the two lowest doses. So at the 2.5 and 5 milligram doses. So that's a vial, like like an insulin vial. If anybody's used that. Wegovy just comes in a one-time use pen. Of course, Ozempic is a dialable pen, so I actually find that easier because then you can just titrate doses. Depending on how someone's feeling on a certain dose. There is an oral form of Ozempic called Rybelsus. And so that's a daily pill. So it's basically an oral semaglutide. However, that's only approved for diabetes. They're currently doing the studies for weight management. But the weight management version of it is going to be at a much higher dose. And so it has not been approved yet. But I have a feeling probably by 2026, we're going to have a little bit more data on that. I think right now the companies are just trying to keep up with the demand for the injectable agents.
How is that demand doing? I think last year we were talking about shortage.
Yeah. Actually, so we're in a good spot in terms of supply. And so both of the medications are actually off of the drug shortage list, which is important. This is the first time we've seen it in like 3 years. It's been really tough kind of managing, the shortages. And of course, patients end up not being able to get their medications and, round and round we go. But we actually, both medications are currently off the shortage list. That also brings me to speaking about compounded medication. That is something that is not FDA approved. So especially, oh my goodness, especially in this population that has had, heart conditions and diagnoses, I would absolutely not go for a compounded version of Ozempic or Wegovy or Mounjaro or Zepbound. Please do not do that. We've had actually, I just up until now, there was a report of about a dozen or so deaths nationally, but now we're hearing of many more. And so I can actually tell you 162 deaths is actually the most recent report out of New York Post today. So from the compounded agents, we're seeing over 150 deaths now nationally. And here's the concern, right? There's so much demand for these medications, which as a physician, I fully appreciate because I've been doing this with my patients now for years. And in the setting of shortages and all of that stuff, some of these compounding pharmacies came up and started making their own, whatever it was, whether it was Wegovy or Zepbound or whatnot. The thing with the compounded medication is that one, I don't know what's going in it. So I'm not sure what they're cooking up in the back and giving to patients. So truthfully, I don't know what patients are injecting into their bodies when they're using a compounded substance. The other is that we don't have safety or efficacy data on those compounded substances. So the thing is, I don't know if this is the dilute version of the original thing. I don't know if what they're mixing in the back to make it look like the original. We don't know, right? And so there was a study earlier this summer, or like I guess the last summer now. They tested 40,000 pharmacies, compounding pharmacies nationally, with what they were making. 95% of them were found to have impurities. And so it's a dangerous decision to go towards the compounded. Again, we totally understand that there's a demand, for these medications, but from a doctor's standpoint, it's safety first, right? And if we're seeing like 162 deaths or more, from a compounded substance, like there's no way I'm about to prescribe that for my patients. And so, you're going to see lots of online ads for those things. You're going to see things, from like med spas. You're going to see things from like Roe or Hims and Hers or all these like online obesity, management companies. They're all going towards compounded substances, because it's accessible. It tends to be a little bit cheaper, but not that much cheaper, for patients. And also, people feel excited that they're getting something, new. But again, I'd rather that you not take anything than take compounded.
Could you explain what that means? I don't know if people are familiar with what compound pharmacies do.
Yeah, and so they kind of make their medication, right? So it's not the patent. And so the original branded medication gets shipped from either, whether it's Eli Lilly or Novo Nordisk. It should have the brand of Eli Lilly or Novo Nordisk on their product. And like all that branding information should be on there. Now, the compounded though, I don't know where it's coming from. So that means that they're literally sitting and making these medications on their own and calling it, whether it's semaglutide or tirzepatide. So just make sure that you're choosing the right sort of prescription.
These are the same places that do other compound drugs. I mean, some of us take two drugs in one pill. It's the same.
Kind of, but not really. In this situation, we don't have safety or efficacy data on it, right? And the way that this is being done now, is in a much more dangerous manner than something like making an ointment at a different concentration. Like let's say you need a higher concentration of such and such because, whatever your skin rash demands it. That's not the same thing.
Hmm, okay. And there's no regulation of these and what they're doing?
No. So now there's been more and more just legal issues around it. So even like the Illinois Attorney General has delivered a cease and desist to all these compounding pharmacies and med spas and things that are doing it. So lawmakers are aware of this. But the thing is, again, like the problem is so far gone that a lot of patients have gotten their hands on this stuff, and it's quite dangerous in my
What's the
opinion.
cause
So
of
just
death? What are they dying from?
yeah, we don't really know. So some of the things actually we're seeing more and more ER admissions with severe GI side effects.
Mm.
So that's one thing. And then we've heard of blood clots, we've heard of those sorts of things. And so right now, like this is very much under investigation. But we have not seen those sorts of things with the original patent. And so that's the big difference here that we've been, just as like a kind of some history, we've actually been using GLP-1 agonists since 2005. That was the first one that came out. And it was a twice a day injectable at that time called exenatide or Byetta. And obviously, since then, these have become much more advanced. And now it's like a once a week injection. But we have that data for 20 years now, to know that this stuff works, especially in patients with diabetes. And then in the last 6 to 8 years in our patients who have taken it exclusively for weight management.
It seems like the media is flooded with these ads from, you mentioned Hims and Hers.
Exactly. So that's why, I would say the lay public may not necessarily realize. I've had enough patients in my clinic come in and they didn't realize that they were taking like a fake version or a compounded version. And then when I kind of tell them like all this background that I've just told you, they're like, oh, no, please get me on the original. Like I'll do, so it's, we can't play with fire too much here. So, safety first.
Have there been any extreme side effects? And I've also read that people have to really adjust what they're eating to make sure they're getting.
Honestly, yeah, these are really well tolerated. Again, like extreme side effects might be, something like a rare pancreatitis or something like that. And if that happens, we would obviously discontinue the medication. You know, sometimes where people have had changes in their kidney function, most of the time it's due to dehydration. Maybe if they've been vomiting or have had diarrhea or something like that, and that spikes their renal function. And so, that's one reason why we might hold it, but then that might be a safe reason to restart it depending on how someone's doing. other, contraindications is if you have a personal or family history of medullary thyroid cancer, you're not eligible to take it. But again, it's really important to make sure that we understand this as well. So medullary thyroid cancer is a very, very rare kind of thyroid cancer. So patients with a history of hypothyroidism or hyperthyroidism, like Hashimoto's disease or whatnot, totally safe to take it. If you have a history of papillary thyroid cancer, totally safe to take it. So I think there's a lot of confusion, like, oh, I have thyroid disease, I can't take it. Not true. If you only have medullary thyroid cancer is the reason you cannot take it.
I was thinking more about how people eat, because now they're actually
Yeah.
foods are being marketed to people taking this.
Yeah. So again, I get people try to earn money in all sorts of ways, right? Like they've seen a very, very significant, like a lucrative marketing opportunity out of this. So now they're making meals that are for GLP-1. It's ridiculous. So basically what we recommend is eat a diet low in processed foods. So stuff that's not greasy, fatty, because if you eat that kind of stuff when you're taking something like Wegovy or Zepbound, you're not going to feel good. You're just going to feel nauseous, stomach upset, that kind of thing. But even if you imagine, like if you go to, I don't know, a drive-through and pick up like a large burger and fries, you're not going to feel that good because it's just a lot of, grease. So those are the kinds of foods we ask to potentially avoid. If you can't avoid it, eat a smaller portion of it. But typically, what I've noticed is that people's cravings will go down. So that food noise typically tends to shut down a little bit. Um, I think people often say like, oh, I can't seem to get full, or I'm always snacking, or that sort of thing. So that sort of impulse does slow down a little bit, which I think obviously will help with weight loss. People tend to crave sort of lighter, fresher foods. And so, like those companies that are marketing now towards like the GLP-1, they're basically giving you salads with grains, right? Or like a lean protein with like vegetables, which you can easily do on your own if you just go to the grocery store. So, I think again, I wouldn't buy into the hype too much. They're not selling you any special diet that you can't necessarily do yourself. But one of the things I often talk about is culinary medicine. And culinary medicine basically is, how do we navigate our food environment to allow for better health in terms of, whether it's weight management or heart disease or diabetes or what have you. And so it's really, really important to understand how to navigate that food environment to allow for improvement of your disease process. And quite frankly, I think people are really confused because there is so much mixed information out there, right? Like, oh, do the keto diet or do this diet or that diet. Just eat a diet low in processed foods. And if you're really, looking for a diet to like look into, the Mediterranean diet is the one that we actually have really sound data on. We have life-saving data on, like 25% less mortality in patients who have adhered to the Mediterranean diet versus not. And so basically what the Mediterranean diet is, it's high in fruits and vegetables, grains. So grains mean like brown rice, quinoa, wild rice, farro, barley, all those things. And then legumes, right? Legumes, lentils, and so beans, lentils, legumes, all those types of things. And it's just low on saturated fat and processed food. And so, I always say carbs are not the enemy, and not all carbs are created equal. And so, oatmeal is not the same as a cupcake. Like, please eat your oatmeal. Like, that's really good sources of fiber. You can add protein to it. That's a really great breakfast, actually, not the instant kind, though. That's all sugar. But but I think people are really afraid of eating carbohydrates because of all the stuff that we hear in the media and everything. And that's a mistake, right? And so I always I've always make that comparison that like we're not talking about cupcakes and like burgers and fries here. We're talking about like oats and brown rice and wild rice and those sorts of things, and like a farro salad, like that's great. Mix it with some olive oil, have it with some vegetables and maybe like a grilled salmon or like a nice lean protein. That's a great Mediterranean friendly meal. And sure, that has some carbs in it, and that's as it should be, right? We need carbs to survive. Carbs are fuel for our cells. But again, a cupcake is a different kind of carb. And so, but the thing is, like, again, if it's your kid's birthday or, your grandkid's birthday or something, like, please enjoy that piece of cake, but maybe, a smaller piece of cake versus, multiple pieces, that sort of thing. So it's a lot of mindfulness around, food choices, portions, that sort of thing. But I always say, like, veggies are a freebie. Enjoy your vegetables and don't necessarily feel guilty about eating too many of those because fiber is our friend. Fiber helps our hearts, it helps our guts, it makes us feel fuller. So it's really helpful with weight loss. And then, we want to also focus on making sure we're getting healthy amounts of protein as well. Now that might be different for someone who has, a history of kidney dysfunction and things like that, but that's a conversation to have with your doctor. But
What
great
about
sources of protein are.
pasta?
Yeah, so in moderation, right? Like you could do subs like bonza pasta or lentil pasta or whole grain pasta versus like the regular whatever white flour pasta. So everything in moderation. Like if instead of a whole plate of pasta, eat a smaller plate with a bigger plate of salad, for example. So I never recommend cutting out the things you love in life. But I think like, adjusting portions and taking things in moderation, I think it's always a good exercise, right? And so to understand like how full am I, how hungry am I, are my eyes hungry versus my stomach? And so those are habits that form over time. Like this is not an overnight thing. I will tell you that like pretty much everybody that comes into my clinic has been dealing with weight issues or some sort of metabolic issue for decades, right? They've tried every diet under the sun. And if it was that easy to just go eat healthy and exercise, people would have done it already, right? And so I think that there's a lot of guilt around that. There's a lot of toxicity around food and diet culture and everything, and it doesn't have to be that way. I always say that there's an entire world of food that awaits you. You just need to know how to access it. And I think like part of it is making it fun, and enjoying it because food should be something where, it brings you joy, it brings like family together, it's like it's a socialization thing. But I think there's just so much toxicity around like food, nationally, globally, all of that. And I think people get really intimidated by that. And I think they shy away from it, thinking that, oh, I shouldn't eat anything or I can only eat, meat or vegetables or something. And it doesn't have to be that way.
You caught me on my cupcake day, doctor. I have to tell you.
Enjoy it
Every
in moderation.
grocery shopping because it's senior day at the local supermarket. So if I buy the cupcakes at a discount, it's not as bad. That's my philosophy. But I had a Greek salad for lunch. So my wife.
Lovely. See, everything in moderation.
I traveled a lot in December and I found it so difficult to eat healthy on the road.
I agree. I think even we were traveling over the holidays and I was thinking to myself, like, doesn't anybody eat vegetables? Like, it was really hard to find like even like a non-greasy or heavy salad or like a veggie dish or something to eat. And so, I don't know. I don't know why people are so afraid of vegetables, but embrace it. There's just so many great things you can make with a whole host of veggies.
We'll have to have you back when we talk about eating habits because we
Yes, I would love to. I love talking about food.
have a member of our chapter who is a executive chef at a local retirement community.
Oh,
He's gone through multiple bypasses, so he is kind of a born again chef where he's trying to cook
there you go. There you go.
cooked for us last July. Was it? We were at his place. Anyway, I think we've covered most of the questions I sent you. Is there anything you see on there that we didn't get to? I think
Um,
if anyone else has a question, feel free to unmute yourself and just jump in. Yes.
Oh, one thing I think this was a good question. Will these interact in some negative way with major heart medications for blood pressure, cholesterol, irregular heartbeat, etc.? There are no drug interactions with these medications that we know of anyway. So the one thing that has been mentioned though is if you're on blood thinners. Because the medications slow down gastric emptying, again, transiently or temporarily, when they slow down gastric emptying, it might affect the absorption of something like blood thinners. However, I've had multiple patients on blood thinners and these medications at the same time, and there hasn't really been an issue. But
Is
that's
it
one
mostly
thing.
with like Coumadin and warfarin where they have to get the INR and the vitamin
Yeah,
D and
so
all that?
but this is exactly why you get the INR checked. And so
Right.
that's the purpose of the INR, right? So but I haven't necessarily encountered issues in my clinic doing it, but that's something that on the warning labels and stuff they do list that.
Got it.
Do you have a question here? Go ahead, tell me and I'll pass it on.
So, in regards to heart patients, how does the drug help the heart patient? Is it purely losing weight or does it do something else
Oh, yeah, that's a really great question. And so part of it we don't know. And so when the select trial came out, so that's the major landmark trial that got Wegovy approved for patients with heart disease. So basically, what that study showed was that there was a 20% decreased risk of a major acute coronary event. Which is what that's a landmark, result, right? So that's why, the FDA approved it so like suddenly, and like Medicare and everything followed suit. So it's a very significant result that you decrease your risk of a repeat heart attack, for example, by 20%. So what we saw in that study was that even at 9% weight loss, there was that 20% weight reduction in heart disease or a repeat heart attack. And so it's not all weight related. Part of it is weight related, but we don't know what the rest of it is because Wegovy allows for upwards of like 15% or more weight loss, but we were seeing heart benefits at 9% weight loss. So there is like some theory that like there's a decrease of inflammation and that sort of thing that helps to reduce the risk of repeat heart events. But this is under active investigation. But that's a really, really great question.
So as a follow-up, if that same patient had a 9% weight loss just through diet and exercise, would they still have that 20% benefit?
We haven't seen that, no. And the other thing with just diet and exercise alone is that usually at best, so even if you did like the best diet, best exercise, all of that in the world, you may have upwards of about 5 to 6% body weight loss. The other thing that happens is that when you do lose, let's say you do your fancy diet and all of that, and you lose 45 pounds, I'm just making something up. Your body actually wants to be back where it was because it was more comfortable, if you will, at that weight, prior to the weight loss. So what happens is that when you lose that weight through diet and exercise alone, it actually slows your metabolism down and it makes your hunger hormone levels go up. And so that's exactly what yo-yo dieting is, right? Like you could do some fancy diet, you'll lose the weight, and then over time people tend to regain that weight and they might have kind of expanded their dietary pattern, whatever. Or some people, they say, no matter what I do, I can't seem to get it off, even though I'm eating super healthy. That's a common story as well. And this is not because of your efforts. It's not because of that at all. It's because of physiology. This is because of hormones. And this is exactly why it is so hard to just keep weight off with like a strict diet and exercise alone. Some people can do it, but it also depends on the way that their hormones interact with their brain and their gut. But people who have struggled with weight fluctuations and a history of obesity and that sort of thing, they will be the first to tell you of that roller coaster up and down that they've experienced, with every diet or whatever that they've tried in the past. And I always say, like, if it was easy enough to just do like the diet and exercise, we would have done it already, right? Like there have been decades now of like diet culture and various exercises and things like that. And this is the first active solution we've had. So what these medications do is that I always say as well, like the medications are doing 2% of the job. You're doing the 98%. So the medication's not like a freebie. It's not a magic bullet, nothing like that. But if you're doing that diet, exercise, all that stuff, the lifestyle stuff, it allows you to succeed for a much longer period. And so it basically suppresses those hunger hormones. It keeps them suppressed so that you can thrive with your day-to-day lifestyle.
Has anyone taken this long enough for that effect to go away? Or do we know is it forever as long as you're taking them?
Well, I mean, we treat weight like we do high blood pressure, cholesterol. It's chronic, right? And so, let's say you've been dealing with weight issues for the last 30 years. Giving you a medication for 6 months isn't going to change that. That's a drop in the bucket, right? Like this is a long-term thing. And the thing is, like, let's say if I stopped your blood pressure medication or I stopped your cholesterol medication or your diabetic medication, those things would go back up, right? Same thing here. If I stop this, your weight goes back up.
So are you saying that once somebody's on Ozempic or Wegovy, they're pretty much on it forever?
Certainly.
Is there ever a case where you would recommend someone stopping, Or is that when they start gaining the weight back?
Yeah, so one reason to stop is they don't feel good on it, right? Like if they are feeling really sick or something like that, then sure, I'm not going to make someone take something they don't feel good on. Some people, if let's say if they're losing weight rapidly, will hopefully decrease the dose and allow that to slow down. But typically, what I say is that maintaining the weight is just as much of a success as losing it in the first place. So as we ramp up on the dose, certainly people will have that weight loss, but then we stay at that highest dose and keep patients on it to allow them to stay at that weight, right? And certainly there may be fluctuations, give or take, life stressors happen, vacations happen, all those things, right? Life gets in the way. However, you're certainly not going to regain back that 50 pounds or 75 pounds or whatever that might have been. I've had situations though where, I've treated patients long enough on this where they were thriving, prior to COVID, all of that, healthy lifestyle, everything. COVID hit, stressors, all of that stuff with the stressors happened. And I have this like very particular patient of mine who she had lost over 150 pounds um on Ozempic. She had diabetes and a history of a heart attack. That's how she actually ended up in my clinic, but she had diabetes. So we had her on Ozempic, and this is back in I want to say what, 2018, 2019. She was thriving, had a very, very significant weight loss. I think she was over 300 pounds previously. Um did really, really well, everything. COVID hit, super stressed out, family history, family issues, all of this stuff, started to regain weight. She never stopped the Ozempic, but the dietary stuff really changed, right? She started to stress eat, whatever, like going through the drive-through, the processed food intake really increased, movement, exercise really decreased. She regained like 75 pounds doing that. And so we're sort of on this journey again to kind of get her back. And I would say the second time around, it's like a lot harder, right? And so that's why I say like maintenance of that weight loss is just as much of a success as the original weight loss. And so these sorts of lifestyle changes. Now, I'm not about to put somebody on a 1,000 calorie diet and like crazy amounts of exercise to try to get weight off because that's not sustainable. So I always say like, if you can see yourself eating like this for the next 25 years of your life, well, you've got yourself a good routine and a dietary plan, right? And if you're doing that about 85% of the time or so, then great. Like this is something that's sustainable. But if we put somebody on a super low calorie restricted diet and expect them to fly that way for the rest of their lives, it's not going to work. And so everybody's lives are different, everybody's situations are different. We have to make sure that we are working with someone's resources, their lifestyle, like what they do day to day. And so it's certainly not a one size fits all approach. And so that's why it's really important to make sure that you have a doctor that's willing to work with you on that.
There's not a danger that someone could overdo it, like someone like a model or an actor who was obsessed with being thin. I mean, you can.
Well, that's been going on, and I think that's one of the reasons, this stuff has gone so viral on social media. It's because some of these people were, using it to get into like some fancy dress or whatever. But we're talking about chronic weight management here. We're talking about heart disease here. So this is a completely different ball game. And so I wouldn't necessarily recommend this for someone to take for a couple months before getting into their dress or something. Like it's not for that purpose. It's for long-term chronic treatment of obesity.
So if someone said that's what they want to do and prescribe it,
No. Mm-mm.
good to know. And that should be any ethical physician wouldn't prescribe it.
Yeah, and I actually don't see that too much. I mean, I hate to say it, but this is, I think, what the med spas are serving more than I am.
Any other questions from anyone? I know we have some folks on tonight who aren't Mended Hearts members. Our meetings are pretty informal. So if you have a question, just unmute yourself and jump in here.
I have another one. You had mentioned the food noise.
Yeah.
And that is something I did not have most of my life until the last 5 or 6 years. Had the heart issue with the stents. Even with exercise, gained 20 pounds. Went on the Ozempic. The food noise disappeared. had to
Mhm.
go off of it, and it came back. How do these medicines, I mean, it's the strangest thing. And
Yeah,
until somebody mentioned those words, I even realized what was
it
happening.
makes sense, right? Yeah.
How does it stop that?
Yeah, so it works at the level of the brain and the gut. And so there's an appetite center of your brain that these hormones interact with. And so it's kind of the same part of the brain that like drugs like cocaine and like, those sorts of addictive things interact with, right? So I always call it like a pleasure center of the brain. And so, like whether it's food or like, others, that's why they're looking into like using semaglutide, like whether it's Ozempic or Wegovy, looking at like addictions like drug addiction and alcohol addiction and
Oh,
things like that because it sort of decreases the impulse onto that like reward center.
do any of the medicines that heart patients take add to possible weight gain?
No, there's some weight gain associated with beta blockers, but it's not enough, especially with the safety of beta blockers to stop it.
Mhm.
And but yeah, there is maybe like some minor weight gain associated with beta blockers, but none of the other heart meds.
I think it's interesting.
That's an interesting point because I can't remember a time in my life when I haven't been thinking about food all the time. And we joke that it's because I'm Italian, but I think it's more
I
than
think it's more than that. It's your hunger and fullness hormones.
I never feel full. I've had this discussion with my wife. Like I never feel full.
You might be a good candidate.
I know it's a little scary, but I fear losing my appetite. I feel like that would be taking a part of me.
Well, it's a balance, right? And certainly there have been patients that have come in and say, no, like I'm not enjoying this because I just can't eat anything. And so, sometimes it means that we have to reduce the dose. Sometimes, if the patient may just not like it and we stop it. There's a whole host of reasons, right? But I wouldn't necessarily rule it out just because of that. Because it might mean a balance, right? So instead of I'm just going to make something up like 2 plates of this dish. You're going to eat one and be satisfied, something like that.
I forgot to ask, what about with type 1 diabetics? Is
Yeah,
is that contraindicated?
nope. We've been using GLP-1s off label with type 1 patients for years.
Okay, thank you.
Hmm.
Anything
It
else?
actually decreases their insulin needs, because insulin causes weight gain. So it's really helped our patients with type 1 actually.
Oh, good.
Anybody else? Anybody want to jump in? Everybody thinking about food now?
Dinner time, right?
He ate before we came to try and deal with that. Although I am kind of thinking about French fries on the way home. Uh, well, thank you. Thank you so much, Doctor. It's great to talk to you again.
Of course. Feel free
Thank
to
you
reach
so
out
much.
anytime. Yes. Thank you for being on. And if there's other questions that come up afterwards, please feel free to send them over to me. I'm happy to do this again. I love talking about this stuff and answering questions. So
I'll address in the chat for everybody, and I can forward them to the doctor if you have questions.
Yeah, thank
sounds
you so
good.
very
Thank
much.
you. This was great.
Yes,
Yes,
thank
Good, good.
thank you.
I'm glad. Thank you. Have a good night, everybody.